to the Q&A. We're going to get as many questions as we can during our discussion. Throughout this series, we have discussed how nutrition serves as both a powerful preventative tool and a means for managing chronic conditions. And as we all know, chronic diseases such as heart disease, diabetes, and obesity continue to present major public health challenges. Evidence consistently shows that healthy dietary choices can reduce the risk of chronic diseases, improve quality of life, and promote longevity. By focusing on balanced nutrition, we can empower patients to take better control of their health and, in many cases, reverse or mitigate the course of disease. In today's session, we're going to review some of the latest evidence on how diet can impact the risk of developing chronic disease. We'll also explore practical strategies to improve patient health by integrating nutrition into clinical care. Joining us today are two exceptional panelists, each of whom offers a unique contribution to this conversation. After this presentation, we're going to move into Q&A session to address your questions. First, I'd like to welcome Dr. Kelsianna Hollis-Hansen. Dr. Hollis-Hansen is a research assistant professor at Tufts University Friedman School of Nutrition, Science, and Policy, and her work focuses on developing and evaluating food security interventions and multi-component strategies to support people living with diet-sensitive chronic diseases. She has advanced research on medically tailored nutrition programs and on improving food retail environments such as grocery stores and food pantries to promote healthier eating and household resilience. In addition to her faculty position, she serves as the faculty director of the New England Regional Collaborative for Food is Medicine program, is a program advisor and consultant on behalf of the Center for Nutrition and Health Impact, and co-directs the Healthy Eating Research Early Stage Investigator Work Group. I'd also like to welcome Dr. Michelle Hauser. Dr. Hauser is the Obesity Medicine Director of the Medical Weight Loss Program in the Stanford Lifestyle and Weight Management Center. She's board certified in internal medicine, obesity medicine, and lifestyle medicine. She also holds the position of Clinical Associate Professor of Medicine, General Surgery, and by courtesy, Primary Care and Population Health. Additionally, she's the President-elect of the American College of Lifestyle Medicine. Dr. Hauser is also prevention researcher and Le Cordon Bleu trained chef. She combines her skills to help patients move away from lifestyles that lead to chronic disease and toward those that promote health and well-being. Full bios for both of our speakers are available on the event page. We're very excited to have all of you with us today, so let's get started. First, we'll hear from Dr. Hollis-Hansen. Dr. Hollis-Hansen, it's all yours.
Thank you so much, and thank you for having me here with you all today. I'm going to actually just advance to the next slide since you already introduced me. I want to briefly share about the state of chronic disease in America. This is the most recent estimates from the Centers for Disease Control and Prevention. So about 8 in 10 US adults have a chronic disease, and about 5 in 10, or 1 in 2, have 2 or more of them. We know now that the leading causes of death and disability here and the leading drivers of our about $4 trillion in annual healthcare costs are owed to these 7 conditions. So heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, and chronic kidney disease. And another thread that goes across all of these is that having an insufficient nutrient intake and poor dietary intake is associated with increasing the likelihood of developing these. And so this is why we're so passionate about finding ways to address chronic disease and using food as medicine and healthy eating practices. Next slide. So I like to ask the question of what nutrients impact blood pressure. And it's a little bit different of a setup. Usually that this is in person and people can directly respond. But I want you to think about this question, and we'll advance to the next slide. And the first thing that comes to people's mind is usually sodium. And it's true, that's a huge impact on blood pressure. And also it's potassium. So we want to be reducing our sodium intake and replacing that with higher potassium foods as well to get a better balance. And that potassium aspect comes from a lot of things that are typically a part of our food as medicine packages. So things like fresh fruits and vegetables, nuts, seeds, legumes. And next slide. But currently in the US, we're eating what some refer to as the SAD plate or the standard American diet plate. This data comes from, or this figure comes from a research organization called ACER, using data from the United States Department of Agriculture on typical dietary consumption patterns in the US. When this was most recently collected a few years ago, about 57.5% of our diet is coming from ultra-processed foods, like bags of chips and croissants or donuts. Only about 30.2% of it is coming from unprocessed or minimally processed foods, like fresh fruits and vegetables, lean proteins, and dairy products. Next slide. And I know I was lucky enough to see Dr. Hauser's slides, and I know that she's going to touch a little bit on the Harvard Healthy Eating Plate. And so I don't want to confuse anyone and make you think that like we're recommending one over the other. I think there's a lot of healthy dietary patterns. One of the plates that I like to use is this Eat Lancet Planetary Health Plate, just because it takes into account things like sustainability of the foods we're eating as well. But it's very, very similar, you'll see, to the Harvard Healthy Eating Plate, which we also support, as well as things like Mediterranean diet and DASH diet. They generally follow these same patterns, which are, at least half of the plate is fresh vegetables, fruits and vegetables, about a little less than a quarter of the plate being whole grains, getting a little bit of dairy foods and animal source protein in there, having a little bit more plant source protein in there, and unsaturated plant oils with just a very minimal amount of things like added sugars. Next slide. And our science-based priorities for healthy eating, and this is based on kind of decades of epidemiological research, are things on this spectrum. Actually, do you mind advancing again? Because it kind of brings up additional, yeah, thank you. And you can click one more time. And one more time. And one more time. Thank you. So if we look at these on kind of the spectrum, at the top, we have our minimally processed foods. And we now, again, have decades of epidemiological research and randomized control trials showing us that things like fruits, nuts, fish and seafood, vegetables, plant oils, whole grains, beans, and yogurt are protective for our health. The other thing they are is also minimally processed. We have things in the middle, which we're not saying, don't eat any of these, but maybe think about and eat in moderation, things like cheese, poultry, milk, eggs, butter, and unprocessed red meats. And then we want to minimize our intake of things like processed grains, starches, sugars, processed meats, high sodium foods, and industrial trans fat. Next slide. And then we have another speaker for this webinar who's going to focus on alcohol. So I know this seems like a kind of awkward detour, but I want to share some of the most recent information that we have, because I know that this is, there's been so much conflicting research over the years, but we're having some pretty large and robust studies come out regarding the health impact of alcohol consumption. So just recently published in June of this year in Nature Health, was this study, which is cited at the bottom of the slide there and will be available as one of the references for this presentation. But it looked at 843 cohort and case control studies to map risk curves across 20 different health outcomes. And when it comes to specifically looking at cancer-related outcomes, it found that there's no safe threshold. So there's strong proof of escalating linear risk, meaning like increasing as there is greater consumption across all 10 major cancers examined. And that even minimal intake or consumption below one standard drink daily had robust links to elevated risks of pharynx, esophageal, breast, colorectal, liver, and pancreatic cancers. When looking at some of the other outcomes, there were what we call robust J or U-shaped relationships for things like type 2 diabetes, Alzheimer's disease, and heart and ischemic heart attack and stroke. Sorry, I'm realizing there's a typo there. But there are high dose risks. So while potential health impacts at low to moderate levels varied by outcome, high levels of consumption were always consistently associated with increased risk across type 2 diabetes, Alzheimer's, heart attack, and stroke. Next slide. And then another study that was published in the Addiction Journal in May of this year looked at 62 pathologies that were fully attributable to alcohol intake. So the ICD-11 codes now have an updated list going from what was previously 48 to 62 fully alcohol attributable conditions, which reflects a stronger consensus among physicians and researchers on chronic organ damage. In this paper, they also codified harm to other people. So what this means is, like, prior to this, alcohol wasn't always connected to things like violence and road accidents, but in this paper, they were kind of sharing information about that as well. And it also found that some harms are reversible. So things like acute toxicity and certain short-term cardiovascular outcomes, they found can recover with within weeks of abstinence. So encouraging, reduction in alcohol consumption can have kind of short-term benefits, whereas chronic fibrotic damage remains largely irreversible, that kind of long-term damage from alcohol intake. So those are just two very large, robust studies that I wanted to share with you to update on the state of that science. Next slide. So kind of looping back to food as medicine after that little segue into talking about alcohol. I like to ask this question. I introduced the sad plate to you, and then the Eat Lancet plate, which I like to call the happy plate. So how do we get from the sad plate to a happy plate? Next slide. And one of the ways, there's many strategies for this, but my research area of focus and what you all are probably hearing about in popular media as well as in the research world are these food as medicine programs. And this pyramid was created by my fellow colleagues at the Tufts Food as Medicine Institute and some of our collaborators like the Harvard Center for Health Law and Policy. And what we have here at the base of our food as medicine pyramid are things like our population level healthy food policies and programs. So these are things like regulations on how much sodium can be added to food that food retailers are providing, or things like sugary sweetened beverage taxes. We also have above that our nutrition security programs. This is like SNAP and WIC and free school breakfast and school lunch. And then these next three parts of the pyramid are what we think of as the core of food as medicine intervention specifically. So that includes things like produce prescription programs, which is where patients receive a prescription for fresh fruits and vegetables, either picked up at maybe a farmer's market or in the medical clinic itself, or delivered directly to their home, like in a box. Or sometimes they're given like a debit card, gift card, or voucher that's restricted to purchasing fruits and vegetables. And these really range in price. I'm going to share about this in a couple of minutes, but typically it's between $50 to $100 per month per patient, and that's to purchase fresh fruits and vegetables or kind of the equivalent provided in that food box. Above that, we have our medically tailored groceries, and this is where more complete food box is provided or gift card, allowing also to purchase things like healthy whole grains, nuts, seeds, legumes, dairy products. At the Food as Medicine Institute, I've spent a lot of time in developing, and again, I'm kind of previewing, but I'm going to share a little bit this toolkit in collaboration with a number of people. And as a part of that, we do have like an approved product list where we make recommendations about what can be included in these medically tailored grocery packages. But they're similarly home delivered to the person or to the patient, or they're picked up at a specific location or purchased using a voucher or debit card or gift card. And at the very, very top of this pyramid, we have our medically tailored meals. And these are typically reserved for people with the most kind of pressing and acute health conditions. So people that are maybe post-discharge from chronic heart failure or complications of diabetes or stroke. and maybe are having greater trouble preparing their own food at home. And so again, these would be home delivered to the patient. They're fully prepared, reheatable meals. And then along all sides of this food as medicine pyramid, we recommend nutrition counseling and education. And I know Dr. Hauser will touch on some of that as well. So next slide. So you might be wondering, like, what is the kind of evidence for this? And I'll admit to you that we are still growing in our evidence base, but so far, there have been a number of systematic reviews that have been conducted, and I've done some myself. And what we consistently do see is that food as medicine programs are statistically significantly improving food security across all types of cohorts. So pediatric populations, adults, and pregnant people are improving food security by participating in these programs, which is kind of like an upstream determinant of diet quality and health outcomes. And that's another thing we do see pretty consistently, is that there is improved diet quality and fresh produce intake from participating in FIM programs. And there have been quite a few studies now showing cardiometabolic benefits as well. So we do see significant reductions in A1C and blood pressure, particularly when the program is targeting patients with baseline type 2 diabetes and high blood pressure. But that isn't always consistent. There are some studies that are not seeing that. So we do have these scientific calls for higher powered randomized control trials. So there was an American Heart Association and American College of Cardiology statements that note that the clinical markers can be inconsistent, particularly in the smaller pilot trials or trials that are shorter. And that's because, I mean, there's a number of reasons that could be, but one of them is because many of those are looking at shorter timeframes too. And we know that it takes a minimum of 3 months to really see improvements in things like A1C and blood pressure. So when you're doing a 8-week pilot trial, it's really important for showing feasibility, but we might not yet see those changes in A1C and blood pressure. But some other great evidence we have, and next slide, is coming from these real world evaluations of existing waiver programs. And I'm going to talk very briefly about what the waiver is, but basically there are states that are able to use Medicaid funds for providing these food as medicine programs for specific patient populations. And so Dr. Kurt Hager at UMass Chan, who is a collaborator of ours at the Tufts Food as Medicine Institute, and a number of our other collaborators, including Community Servings and our team, did this analysis looking at the real world implementation of this waiver. And we looked at 6 months of receiving medically tailored meals and found that there were 31% fewer hospitalizations, 20% fewer emergency department visits, about $3,433 on average of lower healthcare costs per patient. About 98% of the program was offset, the costs were offset. And so really incredible findings. And again, this was, real world, not RCT. This is actually what happened and what we found in this evaluation of the program. Next slide. So I'm running out of time here, but this is a map of where there are currently 1115 waivers. So you can see the green states are where there are approved waivers. We have one in Massachusetts, and there's a number of other states across the country. There's also in lieu of services approvals. Those are in the blue color states. And there's a lot of momentum around this as well. There are pending waivers in certain states too. Next slide. Oh, sorry, next slide again. And again. And again. Thank you. And then back one more. And this is just to say that there are also Medicare Advantage benefits that can be used for this purpose as well, just depending on where you live and the type of services that are provided. So I do recommend anyone on this call to learn about what's available in your state. And then next slide. For sake of time, I'm gonna I think you'll have access to these slides after, but these are just some digital tools that help to support these food as medicine interventions, things like continuous glucose monitoring, and on the purchase of online groceries. Some companies are using kind of nudges or even creating medically tailored grocery carts for patients to help improve. Next slide. And there's huge investment from these private payers in conducting food as medicine research as well. So we convene this network of excellence of healthcare payers and nonprofit organizations that are investing in studying food as medicine. So if you are interested, you're in very good company is one of the things I want to say about this slide. Next slide. And then just very briefly, there's been so much talk recently about GLP-1 medications, which we know are very effective for a number of things, including there is some pilot data and some initial analyses showing that it does also, to connect back to talking about alcohol consumption, there's some great new research showing that GLP-1s are decreasing alcohol consumption as well. And the other thing I wanted to make mention of here regarding GLP-1s is that they're approved for obesity treatment as an adjunct to nutrition and lifestyle. So I think sometimes we forget this piece. And so I really love this figure published by the director of our institute and a number of colleagues and collaborators in this joint statement. So I recommend going back and reading through this, but basically just shows how lifestyle medicine can benefit health outcomes in addition to GLP-1 medication. Next slide. So if you're interested in wondering, how do I do this? Next slide. We have created, in partnership, the Tufts Food as Medicine Institute and the Kaiser Permanente Center for Excellence in Food as Medicine put together this toolkit. I spent over a year of my life working on this, as well as a number of other researchers, collaborators, did major evidence synthesis, did interviews with major stakeholders and organizations to understand how to implement food as medicine programs. And so this URL and this QR code go directly to our toolkit, where you can find information about, like what is the recommended dose? What is the recommended duration? What are the recommended conditions to intervene for the different interventions? Even has things around like recommended scope of work language if you want to create a vendor contract with a food as medicine provider. So there's very, very detailed information, as well as recommendations from all of us who have been doing this for many years. So I highly recommend using our toolkit. Next slide. And you can also reach out to work with us. And I think the last slide is just a recognition of our team at the Institute and a thank you. And I will pass it to Dr. Hauser.
Awesome. Well, thank you so much, Kelseyana, for that informative presentation, to go from the science to the social involvement in this to medical education, which the AMA is very active on. Pretty darn cool for a short amount of time to cover all that. So next, we're going to go to Dr. Hauser. So we're going to hear from Michelle. It's all yours. Take it away.
Thanks so much for having me, and thanks, Dr. Hollis-Hansen, for that great presentation. We definitely have a lot of overlap in our work. So I'll try and highlight some other things. So I'll focus primarily on dietary considerations and strategies for management of obesity. Next slide. Next slide. And here's a quick overview of what we'll cover. This will be, like many of the presentations I give, really meant to be something that you can reference later. I'll give a brief overview of a lot of things on many of the slides, but there are pages of references that I provided in case you're interested in the research background or academic background of any of the comments and multiple things that I'm going over. So I hope you'll take a look later for anything that I don't get a chance to go through in detail today. Next slide. Since we're highlighting obesity, I do want to go over that there is a new way of defining obesity since early 2025 that I think many of us who are here today didn't learn in training, and this might be news. So just to make sure that the recommendations I'm giving make sense in the context of the current diagnosis of obesity, I want to highlight this first before I jump into the dietary aspects. So obesity is now defined either as clinical obesity or preclinical obesity, similar to cardiovascular disease. And clinical obesity is really the disease state. So this is a systemic chronic illness that results from alterations in functions of organs or the whole organism and is directly induced by excess adiposity. Whereas preclinical obesity is really the phenotype characterized by having excess adiposity, but really without any disease or major signs of dysfunction due to that obesity. Next slide. So one might wonder how we confirm the excess adiposity, and a few quick steps here. So if your BMI is over 40, you don't need to do anything else. So it can be assumed with a great amount of certainty that you have excess adiposity. But I think it's a surprise to a lot of people that under that, you really need to do a little bit more legwork than was required previously. And that requires some confirmation of excess body fat. And you can do that at high tech or low tech. So the higher tech options would be something like DEXA, which is expensive and difficult to do repeated measures because of access issues, but gold standard. Then there's bioelectrical impedance, which can be used for anyone who is not pregnant and does not have implanted electrical devices, is cheap, quick, a lot more accessible, and can be used for repeated measures. Or you can use BMI with lower tech options. So BMI plus one anthropometric criterion, or just no BMI and just use two anthropometric criteria. And those would be things like waist circumference, waist to hip ratios, or waist to height ratios. Next slide. And so once you confirm the excess adiposity, then you look for any clinical signs of disease. So if you have any of the multiple conditions here, or there's just age-adjusted limitations of mobility or ADLs, then you would be considered to have clinical obesity. Next slide. And of course, if you don't have any clinical sign, disease state related to obesity, then you would, but you have the excess adiposity, you would have preclinical obesity. And so just like many other conditions, we want to know the severity of the condition before making a treatment plan. And in terms of making a treatment plan, I want to make it really clear, because there is a lot of obesity bias out there, that everyone coming to me has been told, like, eat better and exercise, right? And they've come to me because it's not working, or it might if they got better support, or it might not. I see a lot of people with great lifestyle practices and it's just not enough. So we want to confirm the diagnosis. We want to assess for any contributing factors, not just lifestyle, but also medical. Are they taking a medication that's causing them to be hungry? Do they have a condition that may not even be diagnosed yet, like sleep apnea or other sleep problems that would contribute to weight gain? There are many. I could go on. And then regardless of any sort of treatment we would recommend, as Dr. Hollis Hansen was mentioning, we want to develop a comprehensive lifestyle intervention that's going to be the basis. It may not be the only thing we recommend. We may also be considering things like anti-obesity medications or weight loss surgeries, or other non-surgical interventions as appropriate. But no matter what we recommend, we want to make sure that we partner with and keep our patients front and center. We want to understand their goals, barriers and facilitators to meeting those goals, family and cultural practices, food preferences, resources, and do a lot of work in the food insecurity space as well. We don't want to be recommending things that people can't access, for example, and then maybe utilize some of those great food as medicine resources if we do find a gap. And no matter what, we just want to effectively partner with our patients to maximize their health and wellness. Next slide. So in any obesity medicine assessment that I do for a patient, I'm going to consider all 6 pillars of lifestyle medicine. That would be optimizing nutrition, physical activity, making a plan that's doable for the patient, but includes aerobic, strength training, and flexibility exercises, restorative sleep, which has a lot of components, stress management, assessing their relationships, connectedness, their social support, and then avoidance of risky substances, which I know Dr. Hollis Hansen went into, and I'll go into maybe a bit more in the Q&A, but we want to assess certainly for alcohol intake, but other things that might affect weight or ability to access or use some of the treatments, for example. Next slide. This slide has, again, a lot you could dive into later, but the thing I want to highlight here is looking at the leftmost column, we have percent of total body weight loss, which is a lot of times how we classify the effectiveness of interventions in obesity medicine. So we have the lifestyle in that second green column, the pharmacotherapy under the big purple header, and then surgery at the right. So kind of structured least to most effective. But as you can see, lifestyle gets minimized, but for certain people, it's very, very effective. So about half of people with an intensive, and I should highlight intensive. So this just like, different doses of different drugs, you can have different doses of lifestyle intervention. So with a high dose lifestyle intervention, about half of people will lose about 5% of their starting weight. About a quarter will lose 10%, about an eighth, 15%, and then it drops off from there. And then, as was mentioned, there aren't any types of FDA-approved pharmacotherapy that have been approved separate from a lifestyle intervention. So there's more of a basic rather than intensive, oftentimes, lifestyle intervention. But there's a lifestyle intervention combined with all the approved drugs. And you can see that combination certainly can result in improving weight loss for some people. And then surgery is considered most effective. Next slide. And surgery is always with a lot of intensive lifestyle intervention, by the way, in an evidence-based practice. Here, I want to highlight also, there have been follow-up studies to some of the initial approval studies for some of the GLP-1, some of the more effective drugs out there for weight management. And as you can see, if you add in the rightmost column there with the dark green header, a more intensive versus a basic lifestyle intervention, you're going to get better weight loss outcomes, even when you're using these high-intensity pharmacotherapy options. Next slide. Or next slide. You can tell I like to dictate. Let's see. So now let's dive into the dietary part of this. And it can be really confusing for many of us if we haven't gotten the training that we know is sadly lacking in medical education, but hopefully is changing in nutrition. But certainly patients get a lot of mixed messages as well. So I want to first highlight, well, what even is a healthy dietary pattern and how do you know it when you see it? And so boiling this down to the most simple description, I love the now 25 or so year old few phrases that Michael Pollan said, which was eat food, referring to mostly whole foods, not too much, which refers to portion control, and mostly plants. And so whether or not you have an entirely plant-based diet or not, the majority of what's on your plate, if you're having an evidence-based healthy diet, should be plant foods, ideally less processed plant foods. Next slide. Okay, and so then we want to have some key factors that we want to think about in choosing a diet or prescribing a diet or discussing one with the patients. So we want to think about the problem we're treating. Obviously, I'm highlighting obesity, but you might, like most of my patients, might have 10 or 20 or 30 or 40 things on their problem list. So I want to consider all of those things. Also want to think about, is that problem that we're trying to treat a long-term thing that we need to treat, or is it a short term? And for me, it's almost always long term. So I don't want to recommend something that people can't do forever unless there's a short-term goal, and then we're going to modify that to be a long-term goal. For example, we might use very aggressive approaches to weight loss that might be a very restrictive, difficult to follow long-term dietary approach if someone needs an urgent surgery that they need weight loss for. But outside of that, if we really have long-term to work with, we want to make sure that we're selecting something that's sustainable. And again, we're going to need to partner with the patient to find out what that is. Then we might need to assess knowledge. So we want to engage our registered dietitian, nutrition colleagues and consider other educational gaps. Again, screen for food insecurity or other financial barriers to say, or environmental barriers like access to safe spaces to be active, things like that. I went over a few of these things already, but again, we want to make sure this is doable for people. And then we want to highlight a motivational interviewing or coaching approach. Again, partnering with patients, making sure to assess ahead of time barriers that might get in the way of achieving goals, and then pre-plan for what to do if those happen. And then just make sure that we're in a non-judgmental space where they feel comfortable checking back in with us to make tweaks and adjustments over time. And of course, the best help when we have access to it, although it's limited, is engaging not just our registered dietitian, nutritionist colleagues, but also behavioral medicine psychologists, which can be great, especially in this field. Next slide. This is one of those dive in later when you can zoom in slides, but this is a table I put together that really is meant to highlight that what we choose to eat is a lot less within our conscious control than we think it is most of the time. Of course, we're not automatons. We have some agency and free will, but a lot of times what we think we're choosing to eat might be very little choice and a lot more due to other things. And some of those many things are listed on this table. But just to highlight, if you don't believe me, just to highlight how this might be more likely to be true, is that if we wanted to stay at a consistent weight between age 25 and 65, we would have to consciously choose our calorie intake each day to be within the calories of half a potato chip. There is no one on the planet that can do that I know of, and certainly even with the most training, you can't consciously do that. So the disease of obesity is partly the dysregulation of the system that is working behind the scenes, without our conscious effort and is affecting, energy expenditure, what we eat, and a whole variety of other things. Next slide. All right, so let's talk about those evidence-based dietary patterns for weight loss in the time we have left. So the highest strength of evidence is a calorie-restricted diet. And so this would be 500 to 750 fewer calories per day than would be the number for weight maintenance, or about a 30% energy deficit. And that could be done by prescription, or, focusing on calories and then specifically cutting them back, or it could be achieved through other means, meaning that you eat what you want, but because of some restriction of foods or food groups, you achieve that calorie restriction without intentionally counting calories. There are a wide variety of options to choose from, and I'd recommend that you check out the reference at the bottom of the slide, but for the full list. But again, pick what's going to be sustainable long term, and then also consider what else health-wise is going on with the patient that you're working with, or maybe for yourself if this is for some self-education. Some examples that are in this list, in this particular reference, are dietary patterns that are rich in whole foods that can provide additional health benefits, macronutrient targeted diets for energy restriction, which could be things like ketogenic, low carb or low fat diets. There's also time restricted feeding, which is the more technical term for intermittent fasting. There's no, I'll go into some more details about that in a minute, I guess. I'll save that. Next slide. So I'll just highlight a few healthful dietary patterns. This is by no means exhaustive. As Dr. Hollis Hansen mentioned, there's many, many ways to get to a healthy dietary pattern, but one of the most researched perhaps is a healthy Mediterranean dietary pattern, which is shown by this infographic. Next slide. And the formatting is a little weird here, but I think it's still largely visible. But this infographic put out by the Harvard School of Public Health, which you can see in about 25 different languages if you want it in a different language free online, is I think a more approachable, practical way of it, trying to see if you're achieving a largely healthy Mediterranean type dietary pattern, and it can be modified for other dietary patterns. But it uses the plate method to indicate, again, about half of your plate being vegetables and fruits, and then the other half split, relatively evenly, although it can vary based on a variety of factors between healthy proteins and whole grains. And that's just for overall health. For obesity management, I've taken my knowledge of the literature and other healthy diet recommendations and made color-coded boxes on the side. And this is the slide I think patients that I work with always find the most helpful. So, for example, blue goes with water, the brown goes with whole grains. But those are the tweaks to take this plate and make it more focused on weight management to maximize the dietary impact for those things. Next slide. The American Heart Association highlights a heart-healthy diet that also highlights achieving a healthy weight and maintaining it, which again is, you'll see a pattern here, rich in whole plant foods, minimally processed foods, and minimizing the alcohol, the ultra-processed foods, and foods rich in sodium and added sugars. Next slide. Okay, and then again, as mentioned, I'm president-elect and very involved in lifestyle medicine, and so I want to highlight the plate that we use, especially if someone's eating a plant-predominant diet, which of course we would encourage and recommend when that's something that can be done sustainably. And similar to the Harvard Healthy Eating Plate, I color-coded some tweaks to make this healthy diet overall a little bit more specific for weight management using evidence-based recommendations, in case anyone needs it for a plant-based diet. Next slide. Okay, so I'm going to briefly touch on some evidence for the dietary patterns that I've shared. And at the end of this presentation, I was told there will be pages on the website with all these references. There are many. So evidence for a plant-predominant dietary pattern is that these are associated with decreases in all-cause mortality, weight loss, and favorable changes in lipid profile, decreased risk or improvement in established cardiovascular disease, reduced risk of some types of cancers. Obesity is one of the top contributors to cancer in the United States, so having a diet pattern that also decreases risk of cancer independent of the weight management aspects can be really crucial for a lot of people. Reduce risk of diabetes and improve glycemic control, reduce markers of early stage biopsy-proven prostate cancer, and many other health benefits. Next slide. There's also time-restricted feeding. This slide, in case you're interested in the details, just goes into a lot of the popular types of intermittent fasting or time-restricted feeding. But for sake of time, we'll go to the next slide. Time-restricted feeding or intermittent fasting is just essentially restricting your window of eating to be narrowing how many hours a day you eat to achieve calorie reduction. And in case you're interested in a lot of the outcomes or some key studies in this area, I've referenced those for your perusal later. But the main thing to take home here is that there is no additional benefit of intermittent fasting or time-restricted feeding over the calorie restriction achieved. So if this is something that helps someone achieve calorie restriction and other approaches don't, it might be a good option, but there's nothing else magical about it. And it has similar outcomes for disease outcomes compared to the same amount of calorie restriction through another eating method. Next slide. All right, then there's ketogenic and low carb diets. So these are very popular. A lot of people have heard of these. The terms are used interchangeably and they're definitely not the same. So just to make sure we're all clear on what a ketogenic diet is it's a high fat diet. Most people think it's a high protein diet, and it's not a high protein diet, it's a high fat diet. If you have a high protein diet, you will not be in ketosis because you will convert that to other factors that will make you no longer in ketosis. So someone says they're doing a keto diet, I ask if they're testing for ketosis. If they're not, they're probably not doing a keto diet. And then if they say they're doing a low carb diet, you also want to ask a little bit about that. Oftentimes they're just trying to restrict processed carbohydrates and they're also not having a low carb diet. So you really want to get more information if that's important. Next slide. All right, there is a lot of evidence out there for ketogenic and low carb diets. I don't have time to go through all these, but I'll just highlight a couple key points here. So the second bullet shows that there is about a twofold hazard ratio for cardiac events in observational studies of those following low carbohydrate, high fat diets, which is lingo for ketogenic diet versus standard diet. Other terms used for ketogenic diet are very low carbohydrate ketogenic diet or very low calorie diet. So other than increased risk of cardiovascular events, it can be very effective in helping manage glycemia, reducing dramatically the insulin needed for management of diabetes. But I am hesitant to recommend this to anyone with diabetes who is usually at a higher risk of cardiovascular disease because of that increased cardiovascular disease risk. And honestly, some of the highest LDL cholesterols I've ever seen are in people eating ketogenic diets. But I want to highlight a couple comparisons. So there's one study here, the third bullet, which compared the ketogenic diet to Mediterranean diet. Keto diet was faster at weight loss, but they achieved the same amount of weight loss. And what's important to note is that in the Mediterranean diet group in that study, waist circumference and fat mass reduced the most, and fat-free mass, or what we use as a proxy for muscle mass there, was increased. So definitely healthier overall markers of that dietary outcome, even though it took longer. And then at the bottom, the last bullet there on the page, they compared a ketogenic diet with a low-fat plant-based diet and let people eat. It was not calorie restricted. People could eat whatever they wanted, but they checked, when people ate to satiety, how many calories they ate, and people ate fewer calories on the low-fat plant-based diet. So important things to consider. Next slide. All right, and then I just want to leave you with a resource. So one thing I didn't get a lot of time to talk about, and it wasn't really the focus, was just the field of culinary medicine. So you might be thinking, with everything that was presented today, this is great, but how do we go from the research to execution? And a lot of tips for food as medicine were shared. But if you or someone you know or a patient you're seeing has the ability to cook or prepare food, or someone in their family is willing to do it, it can be great to review something called Culinary Medicine. There will be the first board certification in this, hopefully next year, through the International Board of Lifestyle Medicine. But culinary medicine is an evidence-based field that brings together nutrition and culinary knowledge and skills to help people move toward healthier diets that also are sustainable because they're delicious and tasty. And this is another tool in the toolbox. It's not meant to replace other healthcare. It's just meant to make healthy eating more sustainable. And this is a free resource that I put out. It is with the American College of Lifestyle Medicine. It's the second edition of the culinary medicine curriculum that's been used in over 100 countries now. And this is the written version that you can also use to run a course if you want, or run mini sessions with patients. There's a lot of tips on how to do that. There's also handouts, videos, and whatnot to go along with that. So you can download that there if you're interested. Next slide. And then this is the patient facing version, or just more engaging, I think. So this is all the stuff that's just healthcare provider focused removed, and everything else there, which is still largely appropriate for healthcare providers, is available as pretty handouts, nice videos that go over nutrition, cooking skills, and how to develop flavor in these healthy foods. And let's see, next slide. There's 8 sessions that you can go through that build nutrition knowledge, cooking skills, and lots of tips for sustainability of these healthier plant-forward dietary patterns. And I've done this in person with a lot of people. They come out being great cooks at the end who can really, make up things on the fly and eat tasty, delicious food and not really have trouble incorporating more plants in their diet. So I hope you try it out and you find that as well. And that's also free and available to anyone that wants it. We'll have it up, at least the handouts, in Spanish shortly, but right now it's all only in English. Next slide. Okay, and again, here's the links if you want to download or access any of those materials. Feel free to reach out to me, and I'll be happy to take questions in a minute when we get to that part. Thanks for your time.
Awesome. Thank you so much. A big thanks to Kelsey-Anna and Michelle, for both of you guys, for sharing your expertise on nutrition and how we can use nutrition that's going to prevent and manage chronic disease. So we're going to move into questions now. We just got a little over 10 minutes left. And so we're going to start with some of the questions that we got from the audience. And so why don't we start with this one? So Dr. Alice Hansen, how do you address the hesitancy and the challenges that lifestyle changes, how they affect your patients, right? So they might have an interest in it, but they're kind of in various places on the level of that interest. So how can you help patients with long-term success with these changes?
Yeah, and I just want to reiterate, I'm not a physician, so I do end up interfacing with patients sometimes, but I more so intervene on the community side of things, or outside of the medical office. But one of the things I like to think about, is really asking the patient just out to start, like, what are your favorite meals? And then kind of breaking down what type of healthier food swaps can be instituted based on, what we know about healthy dietary patterns. So if someone tells me, like, I don't know, it's the first thing that came to mind for some reason, but like, I love sloppy joes, which are, like these typically highly processed, come in a can, which is like what I grew up eating. So there's no judgment there, but we can think about, okay, can we swap that ground beef for some lentils or some ground turkey? Can we look at like what the flavor profile is and find like chili powder and like a low sodium chicken broth to cook this up in a way that is still tasty? And similarly, kind of just understanding what are the comfort foods and what kind of changes people are comfortable making, and kind of go from there. And in the kind of programs that we provide, like medically tailored groceries, a lot of times we collate them together as like a meal kit, for example, and we spend a lot of time in developing those programs. Just as one example, for a large grant that I now have, we did 2,000 taste tests. We did 200 cross-sectional surveys. We did focus groups, and you don't have to go to that extent, but like taking the time to really listen to your patients and understand what type of flavor profiles, what type of resources they have, what type of cultural foods are most resonant to them, and then kind of trying to align that to the healthy eating guidelines.
Thank you. Michelle, question about, can you speak to diet strategies that can mitigate risk for specific groups like cognitive impairment, whether that's Alzheimer's or dementia in general? What are your thoughts there about strategies for them specifically?
Yeah, I get this question a lot. And so I think the research that's come out most recently, really highlighting the MIND diet, which is just a flavor of the healthy Mediterranean diet, is great. And it also incorporates, again, a lot of whole plant foods, but also enough variety that I think you can tweak it and to meet a lot of different flavor profiles and preferences. And what's nice about that is not a different diet than would be helpful for reducing cancer risk or cardiovascular disease risk or helping with weight management. So it's why I do like that approach for a lot of people, if they're able to do that, is because it just can be across the board for many, many conditions very helpful.
Cool, thank you. And so a question for either of you, just chime in. So question, if I eat 8 to 10 servings of fresh, frozen, raw fruit and consume about 100 grams of natural sugar from that fruit, is that detrimental?
Is this referencing like like extracted sugar, like if you had like purified fructose compared to the frozen fruit, or does it mean within that frozen fruit you're getting that much?
Within that frozen.
Okay, yeah. Um, well, one, and I'm going to say you might want to jump in too, but um, I always talk to people, it's all about balance. If you overconsume any one thing, then you have to think about, well, what am I not consuming? And that's why I really like the easy, practical plate method, which is, even if I'm not having everything separate like my toddler, I want to have it. If I separated everything on the plate, what relative proportions would I have? And if I'm, with that many servings, you'd have to have multiple plates of just fruit, right? And so we might got a lot of good in there, but we'd also be missing out on a lot of other things. And certainly for anyone who's concerned about blood sugar control, that would, even though it's natural and overall healthy, it's just so out of balance that it could still increase blood sugar. So we'd want to do things that would reduce that blood sugar spike, like pair it with some lean proteins and other maybe lower sugar, high fiber foods, just to make sure that we're still eating in a healthy way.
Mm-hmm.
Healthful fats can help with the glycemic impact too.
Got it. Dr. Alice Hansen, just curious about Tufts based on this question. So does the toolkit give insight on how to get involved as a medical student? What kind of medical student involvement are you seeing there?
Yeah, so there's quite a few ways. And Dr. Hauser can probably share too from like the culinary medicine lens, because it comes up there a lot. So I know one of my very close friends and collaborators is Dr. Jacqueline Albin at UT Southwestern Medical Center. And I'm sure you two know each other and collaborate. But she has a really incredible culinary medicine program that actually trains medical students in that practice and things like shared medical appointments. So medical students are very involved both in learning that training themselves so they can then go on to teach that to their patients, but also they're involved as sort of program assistants in delivering that to the community as well. And then similarly, I've worked with a number of medical students to help with developing the food as medicine packages. So I do a lot of the on the ground implementation of this in collaboration with like federally qualified health centers and food pantries. And so we've had medical students work with us to actually help collate those meal kits and put them together, or do coaching with our community members or patients. So definitely a lot of space and encouragement for med students, especially considering that they're the future of the field.
Yeah, I agree 100%. For either of you guys, it's an interesting question. For a long time, people said that 1 to 2 alcoholic beverages a day was okay, and maybe even had a health benefit. And it seems like the evidence has changed recently even. So could you tell us about what the current state of that evidence is?
Yeah, do you want me to jump in? I know you had slides on it, so feel free. So I think especially in obesity medicine, there's not really a safe amount for anyone I see, because everyone I see is at pretty significant risk or already has established metabolic dysfunction associated liver disease or fibrosis and MASH. I also see a lot of people who've had cancer and are coming to me to reduce their risk of recurrence, because obesity is linked to things like breast cancer, which we know is also linked to alcohol consumption. So there's in that J-shaped curve, there's maybe a little benefit for a really narrow range of people, but you don't ever know if you're those people for a cardiovascular disease with really small amounts. But if you're at risk for really anything else, then the risk can outweigh the benefit. So since it is a liver toxin, unless someone's really thinks it's important to them and we work on minimizing your risk mitigation, then I'd really recommend abstinence. And certainly for obesity medicine, it's empty calories as well. So anything you want to add? I know you had some great up-to-date references in your slides, Dr. Hollis Hansen.
Yeah, I saw a slide there. We went so fast that that's why I wanted to get to this question. But yeah, anything to add there, Kelsey-Ann?
I don't think so. I mean, I think one of the things that I mentioned during the presentation too is thinking about like how different pharmacotherapies like GLP-1s can also be used to help with that. And then of course, always coupled with lifestyle medicine to ensure that people are getting enough variety of healthy foods and high protein and things like that too. So, and similarly, I think food swaps extend to beverages as well, right? There's a number of ways that you can make lower sugar like replacements. And that's been a really interesting and maybe like positive development, I think, in terms of like food retail production of kind of the alternatives that have come out, which is great.
So here's a question that's basic but important and related to the excitement that people have when they start to learn about this and listen to this conversation. So what can individual physicians that are interested and even passionate in helping to expand food as medicine programs and interventions, what kind of advice do you have for the person down the street in Flint, Michigan that might be interested in this because they happen to hear it?
Yeah. Let's see. I guess full disclosure, I grew up as someone who's food insecure myself for a good portion of my childhood, and I grew up in a rural area, so it really hits home. And so I would, I always highlight whatever you can do is 100% better than doing nothing, and that could be in diet or physical activity. So no one should ever be shamed or guilted for what they have. And then, and it's important we screen for these things, but just trying to do some of the things that Kelsiana had mentioned earlier. So assess for what people like, what they have access to, and then, try and make some recommendations or tweaks based on that. And I think people find it a lot more sustainable to do, small stepwise changes. And I think especially in a setting where resources are limited, then that is, just having very discrete, this is what we're going to try and do. Let's check back and see if it worked, can be really helpful and really achieve some degree of feeling successful. And then we can build on that next time.
And I
Kelsey, what
think,
would you
I
say
mean,
to that person?
yeah, there's so many things here too. I feel like depending on like what what facet of healthy eating or food as medicine you're passionate about. So, there is, I, again, I'm not a clinician, but work with so many and have so many that are my friends and understand that like the amount of time you have to see patients is so minimal. And so, there is the potential that you don't really have time to do some of that screening and referral yourselves, but there's so many different pathways where, you can build things into the electronic health record. You can institute a new workflow with medical assistants or interns or dietitians or social workers or community health workers that can kind of execute that on your behalf. And then it goes in still to like patient discharge notes or patient end of visit notes. So a lot of these different like pathways of implementation are referring back to our toolkit are there. And similarly, like the ACLM Culinary Medicine Toolkit is incredible and provides some of that information too. And I do want to mention like one of the things I'm really interested in continuing to assess is like the physicians I talk to that implement culinary medicine or food as medicine are so happy to be doing it. And so there's some very early evidence to show that it like reduces physician burnout, increases satisfaction and well-being for the provider themselves. So I also think there's a really cool aspect of this that like goes back to benefit the workforce too. So just wanted to mention that as well.
Yeah, it's a great observation. I mean, as immediate past president of the AMA, I'm traveling the country talking to physicians about all the challenges. And so you tend to see a lot of, like serious distress even in their faces. But when I went to the lifestyle medicine conference, like the energy, the enthusiasm was amazing. So it was very motivating. Dr. Hauser, we get a lot of questions about specific chronic diseases, psoriasis, fibromyalgia, Hashimoto's. Could you talk just a little bit about nutritional strategies, and are there specific things that when you interact with a patient with one of those conditions to help manage or reduce their symptom severity?
Absolutely. And one of the things, taking a step back from the actual foods recommended, I also assess for, any limitations in staying on your feet in the kitchen or, ability to access foods, education, knowledge, things like that. Some of the, utilizing some of the resources that Kelsiana just mentioned, which just to follow up on the last comment that you had made, actually worked as a primary care provider in a federally qualified community clinic. It was very low resource, and we did all the things that you recommended, and they absolutely work in terms of integrating food as medicine into the clinic setting. So from theory to practice, it does work. But in terms of these very specific conditions, what's nice is, a minimally processed, a diet based on minimally processed whole plant foods. And especially if you are incorporating oils, some of those unsaturated fats, the ones that come from things like olives, avocados, et cetera, are going to be really helpful and are considered anti-inflammatory. So can be effective in symptom management, but also weight management. So I've just seen people just through weight reduction, the reduction in the inflammatory nature of obesity as a disease can dramatically improve these conditions. So pairing those two things together, if obesity is on the table, can be really helpful. I know our time is short, so I'll
Yeah,
stop there.
yeah. Thank you so much to our amazing speakers for taking this time to provide insights on how we can have meaningful conversations with our patients. We really appreciate the important work that you're doing and are grateful that you're able to share that expertise on this topic. So while this is the final event in a series of webinars we organized on healthy diets and dietary patterns, it was wonderful to hear the expertise and experience of many during these sessions, and just as importantly, hearing your questions so that you can improve your own health and that of our patients. So the AMA is working on additional education about this nutrition, so stay tuned for that. And a link to watching this recording of today's event and past events in this series will be sent to today's attendees. CME, of course, is available for today's webinar, so just make sure you're signed into your free AMA EdHub account and click on the Take Quiz portion of it. And thank you so much for joining us today.
Thank you, everyone.